Hello guys, so today we're going to check on the previously tackled, the MCQ that you had on initially on renal and genitourinary nursing. And the first question on that MCQ exams that in a patient with urinary incontinence, which assessment finding is consistent with stress incontinence? So in a patient with urinary incontinence, which assessment finding is consistent with stress incontinence? So you have different types of urinary incontinence, or what may be binding it to maybe a theological function or something. So if you can see in this question, so which one is consistent with the stress incontinence? Okay. So urinary frequency, inability to void, leakage of urine with the coughing or stress or sneezing, and nocturia. So one thing you need to know is that leakage of urine with coughing or sneezing is which is associated with stress. Because stress incontinence is a type of urinary incontinence that occurs when physical pressure stress on the bladder thus causes unintentional leakage of urine. So this the pressure often comes from coughing, sneezing, laughing, exercising, or lifting heavy objects. So it is most commonly due to weakness of the pelvic floor, the muscle of the pelvic floor, or urethral sphincter incompetence, especially in women who are post childbirth, postmenopausal women, individuals after pelvic surgery. Because if you check on the first question, urinary frequency is just more commonly associated with the urge incontinence, not stress incontinence, or maybe with the UTI infection, I mean urinary tract infection. When the choice B, inability to void, to void, that just means suggest urinary retention, not incontinence. Retention is the opposite of incontinence. Incontinence is the inability not to pass urine. Talk about nocturia, frequent nighttime urination, common in urge incontinence like BPH or heart failure, not specific to stress incontinence. So therefore, the correct answer is C. That is leakage of urine with coughing or sneezing. Ah, yeah. Which medication is commonly used to manage symptoms of benign prostatic hyperplasia? BPH, okay? I know you know BPH. So, which medication is used to manage that? So, we have choice A, furosemide, tamsulosin, uh, okay, then you have metoprolol and omeprazole. So, the question is which medication is commonly used to manage symptoms of benign prostatic hyperplasia? Okay, so I wanted to first understand what is BPH because if you don't understand, you won't get the answer. So, benign prostatic hyperplasia is a common condition in older males characterized by enlargement of the prostate gland, which can obstruct the urine flow. So, when you talk about tamsulosin is a selective alpha 1 adrenergic receptor block. Therefore, it relaxes the smooth muscles in the prostate and bladder neck. It therefore improves urinary flow and reduces the symptoms like frequency, urgency, and nocturia. So it does not reduce prostate size but offers symptomatic relief quickly. So when the question is the one which I use to manage the symptoms, we use tamsulosin because furosemide is a loop diuretic which is or commonly used in antihypertensive. It's used in fluid overload and hypertension, not BPH. Metoprolol is a beta blocker for hypertension and cardiac conditions. It's not related to BPH. Omeprazole is a PPI. PPI is a proton pump inhibitor for acid-related gastrointestinal conditions. Second, the third question is which condition is characterized by sudden or severe loin pain that radiates to the groin and is associated with hematuria? Hematuria is just passing urine with blood. So, which condition causes sudden severe loin pain? Yeah, I hope we are together. So, which condition is characterized by sudden severe loin pain that radiates to loin region, the groin, and is associated with the material. So A, nephrotic syndrome. B, renal calculi or kidney stones. C, pyelonephritis. and then the polycystic kidney disease. So when something which brings in the loin pain that radiates the groin, just that means that it's all the lateral lower abdominal region, and mostly it relate to the what we call the urogenital, or let me just say the renal system. Okay. So, despite the fact that the nephrotic syndrome, renal calculi, pyelonephritis, prostatic kidney, in one way or the other, they have direct linkage to renal system, we have to be very specific. So, when we talk about the kidney stone, or what we call the renal calculi, that is the correct answer. Because the kidney stones, they typically present with the classical signs of renal colic. These signs are like sudden, severe loin pain. Loin pain is also what we call flank pain. So it often comes in waves, radiates to the groin, lower abdomen, or genital area. Hematuria may come because you see those stones can cause what we call the mucosal irritation or trauma caused by the stone as it passes through the urinary tract, the ureter. So some signs which can also come like the nausea and vomiting, urinary agency or frequency, dysuria, that is painful urination, that is if the stones is near the bladder. When talking about nephrotic syndrome, it's characterized by proteinuria, edema, and hypoalbuminemia, not acute colicky pain or hematuria. Pyelonephritis typically causes dull flank pain, okay? Yeah, dull flank pain, fever, and urinary symptoms, but not severe radiating pain to the groin. And then polycystic kidney disease causes the chronic flank discomfort, hematuria may be present, but not sudden sharp colicky pain. So therefore, the correct answer is B, renal calculi. That is what is correct in that question. And the question is a patient with nephrotic syndrome is at risk for which complication related to protein loss in the urine? A patient with nephrotic syndrome. I hope we are together this far. A patient with nephrotic syndrome is at risk for which complication related to protein loss in the urine? A. Hyperkalemia. B. Hypertension. C. Hypovolemia. D. Hyperlipidemia. Now, what is nephrotic syndrome? This is always characterized by, okay, let me just say, just is a renal condition or genitourinary disorder, which is more systemic in a way, but nephrotic syndrome is characterized by significant proteinuria, loss of protein through the urine. So that is more than 3.5 grams of protein per day or equal in urine. So it leads to low plasma oncotic pressure. So with that, it triggers several compensatory mechanism and complication. One of the hallmark is metabolic complications. So at most, the question is a patient with nephrotic syndrome is at risk for which complication related to protein loss. Yeah, so protein loss. So when the protein are loose, so what we call the proteinuria, the protein pass through the urine. Yeah, the liver will now respond. Now, normally hyperlipidemia, that is over secretion of lipid or maybe breakdown of lipid, and therefore there will be too much lipid in the blood. So the liver respond by hyperlipidemia due to hypoalbuminemia. Hypo to mean that the albumin is less. So if the albumin is less, the liver will start to break down lipid. With that, if the liver is responding to hypoalbuminemia by increasing production of lipoproteins, that the lipoproteins now will reduce clearance of lipids and lipoproteins and elevate serum cholesterol and triglycerides as a consequences. So mostly is hyperlipidemia, which will be coming due to the proteinuria. Now I want you to understand this. The protein is lost through the urine. There are many compensatory mechanisms, which of course we have choices such as hyperkalemia, hypertension, hypovolemia, and hyperlipidemia. So why do you think that the patient will have the risk? Okay, because the question is a patient with nephrotic syndrome is at a risk of for which complication related to protein loss in the urine. So the protein loss will bring which complication? Will it bring hyperkalemia, or will it bring hypotension or hypovolemia or hyperlipidemia? The correct answer is hyperlipidemia due to that liver responding to the loss of protein, or what we call the hypoalbuminemia, because when the protein is lost, we'll have less albumin, because the main component of protein in the plasma is albumin. So the liver will respond to hypoalbuminemia by increasing production of lipoproteins. So these are mohates of protein, but they have lipid bound to them, and this now will reduce clearance of lipids and lipoproteins. Therefore, we'll have cholesterol, triglycerides, other consequences. So, what will come as a complication is hyperlipidemia. Lipid will also be increased because we are using lipid moiety to produce the protein to replace the one which are lost. So, when you check on hyperkalemia, not a direct result of protein loss, more related to renal failure or potassium sparing medication. Hypertension can occur in nephrotic syndrome, but not directly due to protein loss. See, hypovolemia, possibly due to low oncotic pressure, but hyperlipidemia is more specific and directly linked to protein. So the correct answer is hyperlipidemia. Okay. Another question is, which hormone is primarily responsible for regulating water reabsorption in the renal tube? Which hormone? Which hormone? I hope we are getting it. We are together. Because if you're not together, talking about which hormone is primarily responsible for regulating water reabsorption in the renal tube. That is always ADH. From your high school, you know that. ADH, antidiuretic hormone, okay? We have choices such as renin, aldosterone, antidiuretic hormone, and erythropoietin. Antidiuretic hormone, also known as the vasopressin, is the primary hormone. I want you to get it. We have vasopressors and vasopressin. Those two things, let them not confuse you. So it's also called as the vasopressin ADH. Is the primary hormone responsible for water reabsorption in the renal tube, particularly in the distal convoluted tubules, collecting duct, yes, and the loop of Henle, some bits of it. So ADH acts by one inserting what we call acuporin 2 channels into the tubular epithelial cells, and therefore it will increase water permeability, allowing water to be reabsorbed back into the bloodstream. So concentrating the urine and reducing water loss, thereby regulating plasma osmolality. Renin, aldosterone, and erythropoietin. Renin initiates the renin-angiotensin-aldosterone system. These one only affect blood pressure and sodium retention, not direct water reabsorption. Aldosterone, it promotes sodium and water reabsorption, but acts mainly by sodium handling in the distal tubes. Erythropoietin stimulates red blood cell production in response to hypoxia and related to water completely. So the correct answer is ADHD. A patient with chronic disease who has been prescribed phosphate binder. What is the purpose of this medication? Phosphate binder. Mm, I don't know if you have an idea what is phosphate binder. So this is a patient with you with a patient with chronic kidney disease. Patient with chronic kidney disease is prescribed phosphate binder. What is the purpose of this medication? At most, when such MCQ comes into play, when you see them, you check on the hallmark or what are the stressed statements or word. That is when you'll now get it right. But if you just assume, because you see, this is a chronic kidney disease, it's not acute kidney disease. Is prescribed a phosphate binder. What is the purpose of this medication? So A, low serum potassium level. B, it lower okay. A, it lowers serum potassium level. B, control blood pressure. C, reduce serum phosphate levels, and D, increase erythropoiesis. Reduce serum phosphate level, that's the correct answer. Because in chronic kidney disease, CKD, yeah, the kidney lost the ability to excrete phosphate effectively, leading to what we call the hyperphosphatemia. So this condition contributes to secondary hyperparathyroidism, renal osteodystrophy, and vascular calcification. So I've said in the CKD, that's a chronic kidney disease. You've stayed with the kidney problem for long. Uh, the kidney will lose the ability to excrete phosphate effectively, leading to what we call hyperphosphatemia, to mean that increase the level of the phosphates in the blood. This condition can bring in hyperparathyroidism because there are too much phosphate, or renal osteodystrophy, or vascular calcification. So when you use phosphate binders such as calcium carbonate and sevelamer, the sevelamer, They work by one binding dietary phosphate in the gastrointestinal tract, preventing its absorption into the bloodstream, therefore reducing serum phosphate level. So when we talk about the lower serum potassium level, this is the function of agents like sodium polystyrene sulfonate, what we call the chiasalate. Chiasalate. So if people have what we call hyperkalemia, you give them chiasalate, not phosphate binders. Control blood pressure. These are managed with antihypertensive like ACE inhibitors or diuretics. Increase erythropoiesis. Achieving you is achieved by using erythropoiesis stimulating agents such as epiotin alpha. Okay. So therefore the correct is C. Reduces serum phosphate level. Which diagnostic test is used to assess renal blood flow and detect renal arteriostenosis? Which diagnostic test is used to assess renal blood flow and detect renal artery stenosis? Used to assess renal blood flow and detect renal artery stenosis. So A, serum creatinine level; B, renal ultrasound; C, renal arteriogram; and D, urinalysis. So we want to assess the renal blood flow and detect renal artery stenosis. So which diagnostic test can you do? So talk about the correct answer is C, the renal arteriogram. A renal arteriogram is also called a renal angiography. Is the gold standard test for that when you want to assess for renal blood flow and and then we detect renal artery stenosis. So it visualizes the renal arteries, assess renal blood flow, detect renal artery stenosis, which is a narrowing of the renal artery that can lead to renovascular hypertension and impaired kidney function. So it involves injecting contrast dye into the renal arteries and using imaging, typically fluoroscopy, to directly visualize the vessels. So we have A, serum creatinine level; B, renal ultrasound; D, urinalysis, and we're going to check them. So why is the correct answer not A, which is serum creatinine level? It indicates overall kidney function but does not assess blood flow or artery potency. B, renal ultrasound can evaluate the kidney size and structure, like Doppler ultrasound, and may estimate blood flow, but it's less precise than arteriogram. Then D, urinalysis screens for kidney disease, infection, or hematuria, but does not assess renal perfusion. So the correct answer here is renal arteriogram. What is the primary purpose of a 24-hour urine collection test? The primary purpose of a 24-hour urine collection test: A, assess renal blood flow; B, evaluate glomerular filtration rate; C, measures protein excretion; and D, monitor electrolyte balance. The correct answer is C, measure protein excretion. The primary purpose of the 24-hour urine collection test is quantify substance excreted in the urine over an entire day, most notably like protein expression, which helps in one, diagnosis and monitoring nephrotic syndrome, diabetic nephropathy, and chronic kidney disease. Differentiating between nephrotic and nephrotic syndrome, that is a key. Assessing severity and progression of kidney damage. But A, things to do with assess renal blood flow, done via imaging techniques such as the renal arteriogram and the Doppler ultrasound, not urine test. B, evaluating GFR, estimate more commonly via serum creatinine and formula like AGFR. So creatinine clearance from a 24-hour urine sample can be used to estimate GFR. D, monitor electrolyte balance, possibly but not the primary reason for ordering 24-hour collection. Another question is, in the assessment of patient with acute renal failure, in the assessment of patient with acute renal failure, which finding is indicative of the oliguric phase? Oliguric phase. So in the assessment of a patient with acute renal failure, which finding is indicative of the oliguric phase? A, increased urine output; B, presence of lung pain; C, elevated blood urea nitrogen and creatinine; and D, hypertension. So the correct answer is C, elevated blood urea nitrogen and creatinine. Because acute renal failure or ARF, now more commonly referred to as acute kidney injury, like Aki, typically progress through three phases: oliguric, the diuretic phase, and recovery phase. So the oliguric phase, the key feature include the marked decrease in urine output, typically less than 400 mils per day; elevated burn, that is blood urea nitrogen and serum creatinine, due to accumulation of nitrogenous waste product reflecting impaired glomerular filtration; and other signs may include fluid overload, that is hypertension; electrolyte imbalance such as hyperkalemia and metabolic acidosis. So when you're assessing the option like increase urine output, that is seen in diuretic phase, presence of lung pain more associated with obstructive cause or infections, not hallmark of oliguric phase, and then hypertension may occur due to fluid retention, but it's not a definitive indicator of Nissan. So that's the hallmark and most indicative finding of the oliguric phase is elevated blood urea nitrogen. I'll call the band. Okay. So I think we'll stop from there. We actually are left with some fee. One question only, I think. Yeah. For the primary nursing intervention of the patient undergoing hemodialysis to develop hypertension during the procedure. So what is the primary nursing intervention for a patient undergoing hemodialysis who develops hypertension during the procedure? Primary nursing intervention. Primary nursing intervention for a patient undergoing hemodialysis and who develops hypertension during the procedure. So A, increase the blood flow rate. B, administer a bolus of intravenous fluid. C, decrease the dialysis temperature and stop the dialysis session and notify the healthcare provider. And then the correct answer is stop the dialysis session and notify the healthcare around. Come on, if he's a MO, medical officer, clinical officer, or any. So, what I want to tell you is that the hypertension is the most common complication during hemodialysis. So often caused by, excessive fluid removal or rapid shifts of in intravascular volume. So the primary and immediate nursing intervention, if you're a nurse, when a patient becomes hypertensive, is to one, you stop or slow the dialysis procedure, especially ultrafiltration. Notify the immediate senior personnel in terms of the healthcare provider for further evaluation and management. Place the patient in Trendelenburg position, head down, if needed to improve perfusion. So other supportive actions like fluid manipulation, adjusting the illicit temperature may follow, but the priority is stopping the source of the problem and stabilizing the patient. So choices such as increase the blood flow rate, this could worsen hypertension and is contraindicated. B, administer bolus of it may be appropriate after consultation, but not the first action. Decrease the dialysis temperature can help prevent hypertension in future session, but is not the immediate priority during the acute episode. So therefore, the correct answer is D. Stop the dialysis session and notify the healthcare provider or the medical officer around or clinical officer. That's all.